We are live.
Good morning, everyone. Good morning, Black Health Matters family and friends. We're going to give everyone a few minutes to join. We'll start in just 1 minute. So hold on for a second. Thank you so much. I think everyone's coming in now, so we're good. We're looking good. We'll give it another 30 seconds or so. I hope you're enjoying the sessions that we have today, and also making sure that you would visit our exhibit hall and see many of the sponsors and participate in our leaderboard, because we had some great prizes there. I also want to remind everybody to go to visit the Myovant booth that's set up in the exhibit hall, along with the Black Health Matters and Guru of Abs and AstraZeneca and many of our other sponsors that are in the exhibit hall. And make sure you stop by the chat room as well and network with your patients, advocates, you know, everyone out there in the community. You never know who you might meet. Okay, we're coming up. So we're ready to start. I just want to say thank you to all our Black Health Matter family and friends out there. My name is Leslie Fontenot. I'm Senior Marketing and Operations Director for Black Health Matters. And this session is going to cover lung cancer. So according to the CDC, African-American men have the highest rate of lung cancer in the US. Lung cancers are mostly caused by smoking, but there are still some other factors. There's no safe way to smoke. Menthol cigarettes are just as dangerous as non-menthol cigarettes. And today, our presenter, Dr. Eric L. Flenaugh, is
We can't hear you.
I can't hear.
Can't hear you.
I think if we've lost her video, her sound a little bit, I can just go ahead and start if that's okay, and we can do the troubleshooting.
Sure. Thank you.
Okay. All right. So yes, my name's Eric Flenaugh. I'm currently work at Morehouse School of Medicine. We practice here in Atlanta, Georgia, out of Grady Hospital. I direct the director of our Advanced Diagnostic and Interventional Pulmonary Service, and have helped to manage some of our strategies for screening and diagnosing lung cancer, and also been involved in the COVID response that we've had recently for about the past 8 months now, so it's a little more than recent. So I want to touch a little bit on some of the disparities of lung cancer, how we sort of managed to recognize and focus on and make recommendations towards early diagnosis and treatment, especially for African Americans, which makes up about 90% of the patients that we see. And then towards the end, just touch a little bit on sort of the COVID pandemic, because we've been very involved with that. And I think that is disproportionately affecting the African American population here in America. So with that, I'll get started. What I want to do today is just sort of, the objectives will be to recognize some of the racial disparities related to lung cancer and COVID-19, kind of categorize the healthcare system challenges that contribute to some of these disparities. Not just specifically on the healthcare system, but also healthcare in general and how these play a role, and identify solutions to overcome some of the disparities both now and in the future. And I'll say it's kind of a short period of time. This is a large, very large topics, both are very large topics. So I'm going to go over some of the basics, and then hopefully we'll have time towards the end to get into some of your very specific questions. So when I think about lung cancer disparities, I really like to divide them into the health of the patients that we're looking at, and the health care that they receive. Things that factor into health, a lot of the environmental factors, you know, pollutions, smoking, socioeconomic status can actually influence or play a role in that. And then there's the biology. What genetic factors may actually contribute towards lung cancer or the risk for lung cancer? And then when we look at healthcare, that's what the system offers, what's available, what we utilize, and how those play a role. And some of those may be some of the system factors. You go to the hospital and they may not have certain, you know, scanners or medications available or diagnostic equipment. And then how healthcare is set up for us to detect early cancer in African Americans. Because if we can diagnose earlier, you have a better opportunity for achieving a cure rather than long-term chemotherapy, radiation, and then bad outcomes. So I've always sort of looked at this when we looked at lung cancer in African Americans and some of the disparities. Is it health versus healthcare? And so taking a look at what we know with Blacks in America, African Americans have the highest US lung cancer mortality rates, despite similar or even less smoking rates than white. So that tells you there's something more to it, because you can smoke the same or even less, but still have the highest mortality rates from lung cancer. African Americans are less likely to meet screening eligibility and criteria when compared to whites. And this is something that's been very, we've been very involved in sort of tracking this and making recommendations. And I'm going to talk about even some of the research that we've done a little bit later and how that's impacting changes in the screening for lung cancer. African Americans are diagnosed at a later stage. So they come in at younger age, and even at younger ages. So younger ages at diagnosed, they have much worse disease. And so there's a problem with not being able to find it earlier and not recognizing why it's more aggressive. And then there's lower likelihood of African Americans receiving standard diagnostic, staging, and treatment options. And I'll talk about that a little bit later. So let's talk about the first one. So when we think about, I'm going to focus more so on the health and health side of this. So this is more environmental and biology. And environmental, probably one of the biggest things I will be talking about is the smoking rates. But let's look at this here. If we take this is from the journal of a cancer journal for clinicians. And if we take a look at some of these statistics, we can see that both for men and women, and these are in African Americans, that lung cancer is probably number 2, following behind breast cancer and prostate cancer for women and men respectively. But if you look at now the death rates, and these are the estimated deaths that we expect to see for lung cancer, you're going to see that this jumps to the top. So even though you have more, and maybe, you know, twice as more prostate cancer, and maybe 3 times as more breast cancer in women and men respectively, that you're going to see that the death rate, more are dying from lung cancer actually. So it's one of the hardest cancers to achieve a cure in for both men and women, especially African American men and women. And so getting into some of the environmental exposures that plays a role, we know that African Americans have a higher incidence per 100,000 people of lung cancer. And so, you know, and you can see it's significantly higher versus Native Americans, whites. We're actually leading this in terms of who's more likely to develop lung cancer. But it's interesting to see, if you look at the smoking prevalence, African Americans are not the ones that are smoking more to develop this type of disparity. So even with almost equal rates of smoking. There's a significantly higher rate of lung cancer in African Americans over than whites. And then look at Native Americans and Alaskan Americans. They are smoking a lot more, especially with men. But their rates are significantly lower. So this tells us something, right? This tells us that there's something more than just tobacco use. There's something that puts African Americans more susceptible and more likely to develop lung cancer, even though they smoke less. And as a learning lesson, we heard this earlier from Ms. Flenaugh, that no smoking is good at all. I mean, there's no safe level of smoking for African Americans because there's something that makes us more susceptible to developing lung cancer. Okay, so this disparity is highest. Now I can tell you over the past almost 21 years that there's been very aggressive efforts through the CDC, through community efforts, through the medical community to really push smoking cessation. Right? And people stop smoking, smoking rates have come down. And respectively, we've seen the incidence rates of lung cancer throughout all populations, all races, start to decline. But even with that, you can see that there's a significant difference here in this red line. This red line represents Blacks, African American men. And if you look at the comparison of all the other races here, you can see that there's still this significantly higher rate of lung cancer in Black men. And so this tells us that this is our target population because there's something more than smoking that's keeping this here. So shift a little bit here and just talk about healthcare and early detection. Okay. So African Americans are less likely to meet screening eligibility compared with whites. Okay, and there's two big studies that have come out in the past, about the past 3 years, 4 years. This is one that we did. What we noticed as we're diagnosing in our hospital, and we diagnosed close to about 180 to almost 190 new lung cancers each year, and 90 to 95% of those are in African Americans. And even with implementing screening processes, we noticed that the recommended ages for screening, which is 55 to 80, when we looked at the African American population, we found that a large number of these patients who actually had lung cancer did not meet the screening criteria. And let me explain a little bit more about this. There's several patients, we had 29, 35, 40 in their 40s that came in with very aggressive late stage lung cancer. And this was not just one or two patients, this was several patients. And what we started to see is even though the recommended ages for lung cancer screening are 55 through 80, that almost 11% of the African American patients that we saw were underneath the age of 55. So we knew that 11% that we knew had lung cancer would have never met the criteria to be screened. And then above the age, we found that there was another 5.5%, almost 6% that would have not met the criteria recommended for screening. So our conclusion was, well, actually we looked at this little, so this was specifically for our population, and this is in Atlanta, Georgia. And we went back to the SEER data, which is collected because Georgia is one of the SEER reporting sites. We found that it pretty much matched what the national data was showing. So nationally, it's still about the same, somewhere between 14 to 16% of African Americans that actually have lung cancer are not even eligible to be screened, which means there was no opportunity for us to be able to diagnose them early. And so we came to this conclusion that, hey, these screening criteria that we have are missing specific patient populations. And perhaps we should start looking at population-specific screening criteria for this. And this was based on age. There was another study that came out, Dr. Aldrich, and she's in Tennessee. And they looked at a Southern Community Cohort study, and they had almost 48,000 patients that they looked at. And they took all the patients that were diagnosed with lung cancer, and they found that only 32% of the African Americans were eligible for screening. So of all the patients that were diagnosed, out of these 48,000, right, only 32% of the African Americans were eligible for screening. The other 68% did not even meet the criteria. It was different. It was more for whites. They met that criteria a lot more, significantly higher than it was. So she started to look at this and say, hey, look, there's something about this. And the reason that they weren't meeting this criteria wasn't because of the age like we found. What they found is it was because of their tobacco use history. So one of the other criteria for screening for lung cancer is that they have to have smoked at least what we say is a 30-pack year tobacco use history, which means you've smoked at least 1 pack a day for about 30 years, and that's how you get it. If you smoked half a pack a day for 60 years, it'd be 30 years. But a lot of African Americans, and this is what I was explaining to you earlier, they smoke less. They weren't meeting that 30-pack year. Some of them were 20, 25 years, so they wouldn't have met the criteria for that. But those are the ones that had were diagnosed with lung cancer. So the conclusion was that not only from our data that we found that perhaps there should be a change in the age limits, right? There should also be a change in the amount of tobacco use, because if you keep that high criteria, we're going to miss a large percent of African Americans in a diagnosis. And then there's other factors which play a role in the system which they're in. One thing is African Americans are diagnosed at a later stage. So this is, again, from the same journal, the Cancer Journal for Clinicians. And we're looking at the stage distribution at the time that their diagnosis, and it's a comparison between blacks and whites. Okay. And unfortunately, this can't be seen. So this column is going to be the earlier stage. This is earlier stage or not much metastasis or spread. This is metastasis to the lymph nodes, and this is distance. So this is widely spread cancer. And this blue is representing whites, and the red represents African Americans. And what you can see is in the earlier stages, you can see that whites have, there's more whites that have earlier stage disease. So the disease being caught earlier, which gives you a better opportunity to achieve a cure or diagnosis. In African Americans, there's not as many in the earlier stage. It kind of balances out in this middle stage where the patients would likely to receive chemotherapy and some of them surgery. But here in the distant stage where you have widespread disease, which gives you less of a chance for achieving curative treatment or achieving a cure with treatment, you can see that more African Americans are coming up and showing with late stage disease. Okay, well, how does this happen? There's two parts that I think are to this. One is, and they all fall into the healthcare system. Okay, so one is, I think that the healthcare professionals that are meant to, are diagnosed, are not, how can I say this politically correct? I don't think I can, are not really doing it as well as they should. Okay, there's some gaps in the process and the training of this. So this was a study, and this was looking at what we call missed opportunities. And these are missed opportunities to diagnose early lung cancer. Okay. So what we're looking at here is the specialty, emergency medicine, oncology, these are pulmonary medicines and other specialties, and surgeons, and then their likelihood of missing the diagnosis. And this is what's seen in the odds ratio here. So the higher this number is, the more likely that they were to miss being able to catch an early diagnosis, whether from a CAT scan or symptoms or whatever else. And you can see that these are the specialties that are most likely going to be involved in treating people or patients with diagnosis of lung cancer. You have your oncologists, your pulmonologists, and your surgeons. And you can see there's very high numbers, which is not a good thing because that means they're more likely to miss out on catching an early stage diagnosis. Meanwhile, the group that was doing the best was the emergency medicine physicians. And we went back and we looked and said, well, why is this? Why would the emergency room have a better job of picking up on some of these early diagnoses? And there's two reasons I think this. One is that when people come in the emergency room, they'll get a chest x-ray, they'll get a CAT scan, all that's done immediately, and they'll find something, and then immediately they can refer them. And they may come in for something else, of broken arm or ribs are hurting or something like that. They get the chest x-ray and they're able to pick up that there's something abnormal, and that's how the diagnosis comes. So that's one good thing. The problem with that is that overstresses the emergency room, because a lot of these should be outpatient diagnoses that are clogging up our emergency rooms and making it harder for other treatments to be given to people that need different care. The other reason falls back in our labs, right? It falls back in the patient's labs, because what's happening here is there is a tendency for populations, especially Black populations, to utilize the emergency room more so as their primary care rather than taking advantage of primary care physicians. And so one shift and one lesson we need to learn out of this is, and I'm going to put myself in that same category, is we, especially Black men, we need to go to the doctor, more readily. I'm sorry, my wife would be here agreeing with me. You need to get up and go. We just need to get up and go to the doctor more often and get those follow-up appointments and make less utilization of emergency rooms as our source of primary care. The other area that comes in is even when there's abnormalities found on chest x-rays or CAT scans, it's how they're managed. Okay, and so this is the managing of, these are solitary pulmonary nodules. So somebody gets an x-ray, they see a little spot or a nodule and say, okay, it's a solitary pulmonary nodule. And they took a survey of some of the primary care physicians to see, okay, how comfortable do you feel evaluating a patient that comes in with an abnormality on their CAT scan? And about 55% of them said, oh yeah, no, I feel good. I feel great managing them. I can work them up. However, only about 21% who actually did the management and follow-up of their own. So the primary care physicians, they say, yeah, we're great. I understand this. I understand the steps to take in terms of managing some of these nodules, but a lot of them don't do that. So what that does to the population that's already not utilizing the opportunity to go to their primary cares, and it means that they get additional referrals, which means another appointment you have to. And we seem to drop off of the radar when it comes to having additional appointments and scans and going back and forth to the hospital, and whether it's you're missing work or it's just you're not really sure that they know what they're doing. We need to get out of that mode and just kind of follow through with that, because about 75% of the primary cares are referring to a pulmonologist, 28% to the surgeon, and 24.2% to an oncologist to do the workup. So what this is telling us is that even though you go to primary care and they're going to recommend going to somebody else, we need to follow through with that and make sure we get to those other appointments. When we actually look back through our data, we found that a lot of the patients that had abnormal findings in their lungs that were suspicious for lung cancer, they were referred out to subspecialists. And they would have maybe 1 or 2 additional appointments, from going to the subspecialist to getting additional scans or getting additional workups. And it's about 3 different opportunities. And after you had about 3 different approaches or 3 different follow-ups that were sent, patients tended to drop off. They didn't stick with their appointment. So we concluded, you know, we can go forward with this. We just need to make sure that we have a very succinct process in our healthcare practice to make sure that we get the patients very quickly in, get whatever procedures or additional tests are needed, and get the follow-up and the next steps done quickly. And we have about 3 visits to do so. Then we also have to say, and the encouragement would be to especially to the Black men, is that we need to make sure that we are following up and we stick through that, right? Because if we drop off, we may be missing an opportunity, okay? And again, utilizing the emergency room is the wrong process that we need to take. The other thing that is a problem inside of our healthcare system is being able to get the proper treatment for early stage lung cancers. So this is a study that came out of one of the bigger pulmonary journals a little while ago. And I'm sorry, when it's projecting, it doesn't look like it's giving you the actual categories. So I can go through the categories. The blue here are for whites. These are white men. This is white women. The red is for African Americans. This is African American men, African American women. These are patients that have come in and been diagnosed with early stage 1 lung cancer. And what that means is the best opportunity for curing this is to have surgery. So these are patients that have the great opportunity with stage 1 to undergo surgery and have a better opportunity to achieving cure, remission or cure, depending on how you look at it. But what we can see is that more white men and white women were receiving treatment, surgical treatment for lung cancer. And then less Black women were, but still it's a pretty close correlation here, right? They're almost equal there, but significantly less were African American men, okay? They're less likely to receive surgery. There were several factors that played a role in this. One were some of the other comorbidities. If there's other heart disease, diabetes, kidney disease that made them poor surgical candidates, then we're less likely to receive this. But the other thing was a refusal or a declining of undergoing surgery. And it's kind of one of the healthcare myths now, but it's still pretty prevalent within the African American population, is that thought process of, if I go to surgery and they cut me open, that it's going to make the cancer spread. We still hear that as of today, and that is not the case. Where that developed, and we've looked into this, so where that developed is a long time ago, when we did not have as good CAT scans, X-rays, that if somebody went for surgery and they, based on the CAT scan or chest X-ray that they had, these diagnostic tools were not good enough to pick up on exactly where and how extensive the disease was. So it wasn't until they actually got in and saw that it had been more widespread, that's when, surgery we canceled it, it wouldn't perform. But that's where the myth developed that if you cut me open, it spreads. The reality is it had already spread. We just weren't able to detect it as well. Now that we have better equipment, better processes, better diagnostic tools, we know that that we can actually find it and it's more accurate. When we say it's early stage, it's likely to be more early stage. And so going to surgery, having a surgery is not going to make it spread because the air hits it. And we need to really get that message out, because what happens is some of the older generation that were working under that premise have sort of said it over and over and over again, where it gets ingrained into the younger generation's population. They tend to avoid going for what would be the best opportunity to achieve a cure for cancer. And it's extremely important that we push this. If you have the opportunity for surgery, if you have the opportunity for curative radiation, or the combination of chemotherapy, to really follow up with it and go through with it. because this is a study that came out of the cardiothoracic journal, and they compared what happens. The basic question was, what happens if there is equal treatment between Blacks and whites for the same stage, same age, same risk factors of having lung cancer? Okay, so if they took just in general all populations, you could see that there was a difference in terms of the survival. So this is the amount of time that they survived with the diagnosis of lung cancer. And you can see that whites were surviving a lot more at a higher percentage than Blacks were over time, 5 years out from the diagnosis of lung cancer. And this is just in general. And a part of that might have been the relationship of, part of this relationship was because of differences in treatment or availability of treatment. But when they broke that data down and they looked at it a little bit closer, when Blacks and whites for the same stage, same age, same risk factors receive surgery for their cancer in this curative intent, get all that cancer out of the body, you can see that the survival rates almost became equal, right? So the thing to take home is that similar treatments will give you similar survivals for lung cancer. So we know we've got to stop using the ER. We have to get to our primary care physicians. We have to stick with the referrals, the other treatments, whatever else, and don't drop off. And then when the treatment is offered at an early stage, we need to take advantage of that. So we looked at this, and this is just a little bit of what we're doing here at Grady Hospital. We're the 4th largest county hospital in the nation. We have our own cancer center within it. And we treat a very large African-American population here in Atlanta, Georgia, which happens to be in the deep Southeast, which is the smoking capital of the United States, pretty much. Okay, and so we put together a grant, and just kind of briefly, we had like $2.3 million over 5 years, just really to look at how can we focus on navigating patients through the system, get them scanned earlier, get them diagnosed earlier, and get them to treatment and diagnosis. And we utilize a lot of navigators, follow-up lines. We give local transportation cards and parking cards to the patients to make sure that they're getting to their appointments. Just really trying to balance out that playing field. And we looked at for lung, breast, and for gynecologic cancers. But one of the things we did is we put together this really intense lung nodule clinic program. And we did so by just speaking with all the other major players in the diagnosis and treatment of cancer. We say, what's going to work best for these populations, especially for the Black population here in Atlanta that we're seeing. And we all put all our information in to be able to get a system to navigate. We did get some, I did have one. This may not play. We did get some, we got equal equipment, state-of-the-art equipment, so we can actually trace and biopsy smaller lesions way out in the periphery of the lung. Okay, and this is only a very early stage lung cancer that we can use some 3D navigated equipment for lesions that may even be like 15, 12 millimeters in size. So very early stage, we can make our diagnosis, get our treatments here. You have lung cancer just developing all the way through here. That's an early stage. It's really small lesion. Even if the patient has bad lung function, it's just easy just to take this little area out, and they have a better chance at survival. And by putting our system together and navigating patients through from screening to a diagnosis to treatment, what we found is this. One of the criteria that's used to determine whether or not you're performing at a good, your hospital is performing at a good level in terms of getting patients treated for lung cancer is to measure the time from the day that they were diagnosed, right, to the day they get their first treatment, whether it's therapy, radiation, or surgery. And we set our goal at 30 days, right? Because we know that if we have more than 3 appointments made for somebody, that they're likely to drop off the radar and not follow up. So we said, let's set it for 30 days, and our goal is going to be get this patient from treatment to from diagnosis to treatment within 30 days, right? And this is where we started in 2013. This is where we're now in 23 days. So from the time we actually know that you have cancer, it's taken us 23 days to either get you into the operating room or get you to surgery or to get oncology, to get chemotherapy or radiation therapy, right? And why is this important? This is really important because when we delay going to those follow-up treatments, knowing that we have lung cancer, that if you get beyond 40 days, most cancers have spread by 40 days. So you pretty much need to start from scratch to find out whether or not they've spread or not. So it's really important not only to get to that early diagnosis, but to get to the treatment and get through that system earlier. So summary on this part is, African Americans are the highest risk for disparate care for lung cancer. Screening criteria misses a large portion of African Americans who are at risk for lung cancer. But look for the new screening criteria. I can tell you that the 2 studies we talked about, that I talked about earlier, our study and Dr. Aldrich's study, has gotten back to the United States Task Force for Lung Cancer Screening and Prevention. And what's going to come out, we've just looked at the prelim recommendations, and if people are giving their feedback. But what's going to come out is new criteria. They're going to change the age and drop that by 5 years. So it'll be age 50 to 80 for screening. And they're going to change the amount of tobacco smoking requirement. So instead of having 30 pack years, they're going to drop it down to 20, which, if you remember from what I said earlier, African Americans were hovering around that 25 pack year on average. So that should increase the number of African Americans that can be screened and meet the criteria. And then we just have to remember that equal care will give you equal outcomes. So we just need to make sure we get in and get those treatments going. And our primary focus is going to be African American men, because right now they are at the most at risk. So in the last few minutes, let's just talk into some of the COVID-19 disparities. I don't have a whole lot on this, so I can make this quick. I know I'm getting close to time. But one of the, this is something that is also disproportionately affecting African Americans in our population. Just keep in mind, across the United States, and these are today's totals, we are at 212,000 and plus, according to the CDC. That's with over almost 1,000 new deaths in the past 24 hours have been reported. So we should expect to see this continuing on. We have not reached the magical disappearing of this disease yet. Okay. So how does this factor in, and what do we need to pay attention to? If we look across the United States at our data, and we take the different ethnic and racial populations, we can see that there's a little disparity both in the cases, the hospitalizations, and the death rates. This is according to CDC data. American Indians, they have a higher risk of developing cases, and all these are compared to white and non-Hispanic persons. So they're 2.8 times more likely than whites to have disease. Asians are 1.1, so it's pretty similar. African Americans here, 2.6 times higher incidence rate of cases. And hospitalizations actually plays a bigger role, because if you start looking at the at-risk patient populations, the American Indians and Native Alaskans, 5 times more likely to get hospitalized. Hispanics 4.6, African Americans 4.7. But here's where it plays, because even though you get hospitalized, you got to see, are you surviving that hospitalization? And here you can see that African Americans are not surviving the hospitalization as much, almost twice as much as any of the other populations here, especially whites. Okay, So things to pay attention to, what is this? Well, what might be factoring is, one is recognition of the symptoms, okay? And we know that there's a timeline. There's a timeline for both the disease and shedding. And I think some of the early symptoms that we see, and we need to pay attention to those around us, maybe fever, the cough, the shortness of the breath, headaches, something that really throws you off from the normal, right? And we've all kind of had flu and flu-like symptoms. But one of the biggest things that's come out is the loss of taste or smell. You get that combined with some headaches or the high fevers, and this really should prompt you that maybe there is something going on. Don't just sit at home with this. That's time to really start thinking about, should I get checked in? And it's also time we really need to pay attention to not only that, but the protective measures, okay? Because you can see that there's an incubation period from the time that develops maybe almost 1 to 5 days before the time that you actually get the symptoms. And the symptoms kind of come along. You get the fever first, and you get the cough, and you start to get the shortness of breath right around day 6, day 5, day 6, your shortness of breath comes along. Maybe you might need oxygen. Maybe you might need to be hospitalized around this time, which means it's been around a little bit longer. And so when you start getting some of these symptoms that persist and the shortness of breath comes, it's really the time that you need to find yourself getting into the hospital, because those are some of the emergency signs, some of the warning signs for COVID-19. So the trouble breathing, the persistent pain or pressure in your chest. If you notice that someone in your family has new confusion, they're kind of, not keeping up mentally with where they were, or they're not able to stay awake, they look really fatigued. Or you start seeing as they're moving around, they get really winded easy, or that bluish lips or blueness in their face or their fingernail beds. That's probably a time to make a move to get to the hospital. And it's been a big problem in the African American population. Okay, this is a map of the United States. We're looking at those areas that are disproportionately high Black populations, higher than the rest of the nation. And you can see here through Louisiana, this is here in Georgia, down in Florida, and then up in the New York, New Jersey area, Philadelphia, some in Michigan, whatever. So that's where a lot of the diagnoses are coming in, is those disproportionately high African American locations in the United States. And you can also see that what follows along with that is the disproportionately high death rates that are coming in those same areas. Okay, and why is this? There've been a lot of looks to see that maybe it reflects a little bit related to poverty, or there's unemployment and people are at home, especially as the jobs have sort of, the job market has fallen off, more employment has come up and they're staying at home more. There's more diabetes, more heart disease in these same areas. And that may all be playing a role as other risk factors which come in. So about the biggest thing we can do is to stay safe. This is where we have to do our part, and we really have to focus in on it. And that's washing your hands, soap and water. You can use the alcohol-based hand sanitizers, but the biggest thing that plays a role is that the friction, right? You get the good friction in there with soap and water in between your fingers. Stay clean and wash your hands several days and sing happy birthday while you're doing it, because that's about the length of time that you need to be washing your hands. Avoiding touching your face. And what I've seen is just kind of some silly things that people don't pay. Okay, you don't touch your face and whatever else, but I've seen people share their phones, right? If you need to share your phone with someone, put it on speakerphone, right? Because that phone was next to someone's face, their mouth. You could have viral shedding there. And the one thing I really saw, somebody, they were using their eyeliner and said, oh, let me use some of that. And they just say eyeliner brush. And I'm just like, no, you guys don't do that, right? We got to really not touch your face and spread it to others. And then avoid, keep up with your fevers, cough if you don't feel well, avoid contact, cover your mouth, wear the mask, social distance. And if you're feeling sick, you need to quarantine yourself and be evaluated. Okay, because this is what's happening here, is even though a lot of the other death rates are coming down, the 7-day average for Blacks in the United States in terms of death rate is still hovering high in terms of cases. And we thought everything should have been better around this time, what we were told, but that's not the case. It actually got worse for us, right? And we're still now hovering at a higher level than we were in May and June. Okay. I want to thank you for listening to me. I want to thank Atlanta. We were really knee deep into this COVID crisis here. They recognized me, gave us some recognition for being a part of that. And with that, if we have time, I'll take questions. Is anybody else there?
I think there are 4 questions, Doctor,
Gotcha.
if you can check that. Yeah. So yours, okay. Can you see that, or should I?
Yeah, I'm looking at I'm looking at the question and answer. So the first question is coming from initials MA. It says, so you're saying lung cancer was there before their 20s? In part. So the thing about lung cancer, you know, if we have somebody that comes in at the age of, 29, and we've had multiple, in their 20s with late stage lung cancer, how long was it there? On average, by the time a lung cancer gets detectable, it may have been there about 3 years prior, because you got to figure it starts from one cell that divides and divides and divides to where it has to get to millions of cells, and that may take 3 months, but by the time it doubles in its volume of cancer cells. So we figured that somebody that's diagnosed with a lung cancer, it's probably been there maybe 3 to 5 years ahead of time, depending on the size of it. And so that's that. I'm sorry, someone's deciding to call me in the middle of this. The next question is, how has your foundation's handling and the disparity in the eligibility of lung cancer Okay, how is your foundation handling the existing disparity in the eligibility of African Americans for lung cancer screening while awaiting change in the eligibility criteria? There's 2 things that we've done. One, we've been very involved in going with the national, working with the American Cancer Society and going to the national roundtables on lung cancer screening and disparities, and just sort of giving our feedback. We put our data out there. We publish our data. We talk about it very often, because if we stay silent and we keep this silent, then nobody ever really hears about it later. And it just kind of stays hidden, and there's nothing addressed with it. The other thing that we've done is we've made very aggressive processes to keep up with incidental findings, because that's pretty much the only way we can make the diagnosis. If we can't really recommend outside of the guidelines for screening. So if we do have somebody that has an incidental finding, we have both a process for the radiologist to report them, and those to get reported to our lung nodule program, and for the emergency room to also report them, and that we can track those patients and get them in for follow-up. Because we got to figure that until we get that control, we're going to have about 17% of patients that are going to be diagnosed. That's 1 out of every 5, 6, about every 6.5, 1 out of every 6 patients that is only going to have the opportunity to get diagnosed by having an incidental finding. So those incidental findings that we come across, we stay on top of those and very aggressively. Let me keep moving. How should biracial patients evaluate their health risk? For example, for lung cancer, should a patient who is African American or Caucasian use a screening criteria that is more aggressive? Yes, I would say that I would take that approach until we really get into a lot more of the genetics and other factors that may be playing a role. I would use the more aggressive screening process and that criteria yeah, I would take the more aggressive one until we get a better idea. I think as we go in time, and maybe 10 years from now, we might have more criteria and more information, how we can better stratify patients. But until that time, I would say yes, be more aggressive on those at risk. Dr. Mitchell, hello. And what type of doctors treat the lungs? Those will be pulmonologists. And that's, sometimes words get a little bit confusing or tongue twisting. Just say, I need to see a lung doctor. Those that do surgery on lungs, those will be a thoracic surgeon. Some young people test positive, however, they have no symptoms. I imagine this is for COVID. Based on your knowledge, what could be the cause of that? It's very interesting. I think there's a couple of things, and this is with respect to COVID. I think a lot of what we see in terms of the severity of the disease is dependent upon patients' underlying immune systems. Some people's immune systems are pretty revved up, it can handle and fight, but they're still able to shed the virus. Others may have immunodeficiencies, which allow the virus to spread more, and they have higher loads, and then it becomes more, I guess the manifestations become more pronounced. On the flip side, that this virus has an ability to trigger an immune response. And you may have heard the term a cytokine storm that comes with that. And, anytime you have sort of an injury to the body or an infection or something like that, you release histamines and interleukins and a lot of other mediators that really make you feel bad. You have the fever, the shakes, the chills. And sometimes your own immune system can have such a huge response that causes some of the complications to develop as well. And so it's really hard to gauge. I think it depends just on the person's intrinsic immune system. But you also have to keep in mind that we are very early in in this disease process. COVID has sort of took us by surprise at a very high level. And I can tell you for about the past 5 or 6 months, there's just journal after new finding after this might work, this might not work, and changes that have come through. And even from different areas of the world and country, because the patient population in China versus Korea versus Italy, which were some of the other countries that were hit pretty hard, differs very much from what we have in America. And you got to think of how it spread across America and with Seattle and then New York, and now in the southeast where we are. Okay, and so we are we're just learning more as we come on. But I'm being reminded that, as usual, I have talked too long. So thank you very much for your questions. Thank you very much for the opportunity to speak, and I'm sorry I took you over.
Thank you, Doctor.